Have you ever wondered why our generation of men's testosterone levels are on a massive decline? Are men becoming less of men? And what's this massive drop in testosterone levels in today's men linked to? We'll find out after this, so keep watching. Hi, I'm Mike, and if we haven't met yet, I'm the founder of Balance My Hormones, the leading HRT and TRT clinic in the UK, and where we support men and women on their journey to optimal hormone balance. In today's episode, we have a very special guest. His name is Dr. McClain. And be sure to keep watching until the end of this video, because we will be covering the decline of men's testosterone levels and what can be done, so you don't want to miss it. So Dr. Rand, he's been treating patients at his practice in the US using regenerative medicine, sports medicine for a very long time. And many of his clients and patients are A-list celebrities and world-class athletes. Some of the treatments Dr. Rand uses include bioidentical hormone replacement therapy. He also uses hyperbaric oxygen therapy, cryotherapy, PRP or platelet-rich plasma, stem cells, and much, much more. Dr. Rand has dedicated over 35 years of his personal, professional life studying nutrition, herbs, and supplements. I'm very excited to talk with you today, Dr. McClain. Thanks for coming on.
Thank you for having me. Great to see you.
It's an interesting topic, isn't this? I guess it's the elephant in the room. Why are men's testosterone levels dropping so low today compared to previous generations?
Well, yeah, I mean, we're nerds, so I'll at least speak for myself being a nerd. But it is interesting, and I'm not sure we have all the answers or even any of the answers. I don't know if we can prove this, but we do know, for example, many years ago now, and I don't remember how they actually test this, but the testicular weight at birth in males has been declining over the last 50 years. And that's a concern because that's obviously the organ that produces testosterone. The theories abound. I mean, I see in practice certainly a correlation between stress and lower levels of testosterone. What starts being a secondary hypogonadism can end up being primary, whether it's because of the stress or the senescence of the Leydig cells in the testicles itself, eventually becoming primary more prematurely than before. Who knows? The other factor that comes with that, sort of as a side note, is I've noticed even when we utilize therapies for secondary hypogonadism and keep the testosterone levels higher, restore them to optimum levels, after some time, patients complain about symptoms of hypogonadism returning nevertheless. So is it concerning just the testicles and the production, or is there some receptor issues going on? Who knows? And then, of course, we get into the other theories, and they're not necessarily mutually exclusive. Xenoestrogens in the environment causing the issue, and of course, I'm not sure even doctors who aren't specializing in this area recognize it, but for the layman anyway, the problem is whether you have high estrogen levels or things that look like estrogen, in this case, we call the xenoestrogens, or high testosterone levels. In either case, the pituitary is not going to send a signal to the testicles to produce more testosterone because estrogen is made from testosterone. So I realize it's a gyp for us men, right? I mean, wait a minute, if my estrogen's high, I still would like my testosterone high, please. But that's just the way it works. And so with these xenoestrogens making their mark, if you will, the body's not going to send, specifically the pituitary, a message to the testicles to do what they're supposed to do. So you can see how that could create an issue very easily. So, I think those are at least two very good theories. But will we ever have proof? I don't know. But what we do have proof of is, we have declining levels across the world in testicular function and levels more specifically of testosterone.
And are you seeing more and more young patients coming to your practice?
That's, I think, more definitive than anything, as you see. And again, is it because of stress or xenoestrogens? I don't think we can prove it one way or the other, but for sure, the observation is, and you probably see the exact same thing, younger and younger patients come in, and you got to ask yourself, what's going on here? Because, some of their grandfathers, for example, whether we tested for it or not, showed signs of having much higher levels of testosterone well into later ages in life, 50 years old.
That's true. We tend to see even some older men now coming in just to get the blood test and see what the testosterone levels are, and we see quite high levels of total testosterone. But some of them who are complaining of symptoms might have higher levels of total, but their free is low and elevated SHBG as you age. But we've seen that also in younger patients as well. I was going to touch on something you said earlier, that there are some men that, and we've seen them too, that come into the clinic, they're on testosterone, and you said that they're still getting symptoms of hypergonadism or testosterone deficiency, and you think it might be due to xenoestrogen?
When you're dealing with the lower titers of testosterone, yeah, I think it's very easy to consider that theory. Xenoestrogen is getting involved, the stress being a part of that or not, but certainly either one of those could contribute or be the sole source for all we know. But I think the other thing I mentioned was even with higher levels of testosterone, not just total, but free, what I've noticed is that patients will still complain. For example, I've got some younger patients, I can think of one right offhand, came in at age 28 with low T. We treated him as a secondary hypogonadism patient. We restored his function, quality of life, et cetera, for about 2 years. He came in for a follow-up, and his testosterone levels were still just as good as once we initially treated him and symptoms were resolved. But he says, Doc, I hear you. I see the numbers myself, but the wheels have fallen off the wagon. I don't feel good. I have all those symptoms back again. And I have other examples before I get to the punchline where I specifically make reference to a 56-year-old patient, a German fellow who's training NBA prospects over in China. And I don't know if any listeners remember a guy named Freddie Dreyer, a football player over here in the United States, but he was known for just being shredded. He looked like, they used to say he looked like, the frogs in the biology department where they dissected everything off and all you had was just the muscle. I mean, the guy looked great. That's what this guy looked like at 56. And his testosterone total was in over the 1100s. And his free was about 16 and a half, something like that. And his main complaint was energy and libido. And I'm looking at this guy saying, man, you have levels that deserve the Guinness Book of World Records notation, and I'm not doing anything to mess with that. So we're going to try and figure out what's going on. We did a lot of things to try and raise his free by lowering his SHBG. Anyway, long story short, after 9 months of trying, I apologized and said, I can't figure this out. And sure enough, whether it's with a 29-year-old who 2 years hence, the wheels fell off the wagon with this gentleman, when we switched to TRT, all symptoms resolved, and both those patients and a couple dozen since, they're staying pat with the TRT and doing very well. I can't make sense of that. Is it a receptor issue that occurs? The other theory I don't want to bore too many of your listeners with is, there's issues sometimes with the testing, I believe. Just like, there's variations on different molecules. Maybe some androgen is being picked up and recorded as testosterone when it's really not. And that might be part of the issue, is that we think they have high levels, but they don't.
Yeah, I've seen this before in blood tests where the patient may be trying to prevent hair loss and they take biotin, and biotin seems to skew the analyzer and gives a really high level of testosterone. And then we get this massively high level, which makes no sense at all, whether the patient's on TRT or even before they get on treatment. And yeah, many times they actually said they're on biotin.
That's a great example, and thank you. That's to the point. Yeah, that's a perfect example, at least one. And I'll bet there are others, because I've seen too many times where if you dig into the way the particular hormone or whatever it is you're testing is tested, you can see where there can be some issues. Briefly, there were some guys we were training on the bicycle team I used to ride with. We were giving them glutathione to help with recovery and preserve their oxygen carrying capacity through preservation of red blood cells and hemoglobin. And all these guys, their red blood cells were dropping, particularly their hemoglobin was dropping. Excuse me. from like 17 something down to the 14s. I'm going, oh my God, I'm calling the pharmacy. Are you sure you're sending reduced glutathione? I mean, what's going on here? I asked all the MD PhDs at LabCorp. No one gave me an answer. Then my old friend, he's not old, but a friend of mine from the past, one of my organic chemistry professors, who's brilliant. I asked him the question. He got back to me in about 3 days. And he says, oh, Randolph, you have to understand. And he went through the whole process. Well, briefly, and I'm being long-winded, I apologize, but they use a sulfur-based reagent to test for hemoglobin. And of course, glutathione being, sulfur-based. I can't remember the details, but just very, very superficially, that threw off the evaluation of the titer. And of course, as soon as they stopped taking glutathione within 3 or 4 weeks, we retested and their hemoglobin levels were up in the 17s again. So these things can happen. And, without funding and desire to go into it, we're not going to resolve these things in the near future. But I just bring it up because, and we were talking about this before the show, you got to remember to treat the patient, not the numbers. And so whatever you see, as long as it makes some sense, and I always follow the rule of, if it looks like, well, if you see a hoof print, you look for a horse before you look for a zebra, right? So we have to use the art of medicine to some degree always.
Yeah, look for the obvious. That's a really good point. But I think there are sometimes, at least in the UK, pressures like we talked about with regulators. But the fact that we at Balance for Hormones, we've got a good understanding of explanations for certain things, and you do further testing, and we do more than just one blood test before someone gets put on TRT. I think it makes a big difference. So I guess speaking about testosterone levels, I mean, what do you think the current testosterone levels are that are treatable in your opinion, or the range of levels that might be treatable for patients that you see coming in? Sorry, I don't mean to put you on the spot.
No, I think it's a great question. I love it because, that's been the question for the ages for so long. Going back in time when they first started, really discovering and fiddling, if we'll call it that, with testosterone, it was in the 40s here in this country anyway. You had all kinds of assumptions made that were crazy based on tests that involved an N of 3, which is not a study at all. But there's a lot of good testing that was performed in the 50s, and to answer your question, back then, 800 nanograms per milliliter was judged as the level of testosterone you had to get to see resolution of symptoms when you were using replacement therapy. Okay, and as you know, that's a very decent level. I've got a friend with a 17-year-old son who's doing great, trying to make the major leagues in baseball with a 550 total T. But it goes back to something we were just referring to earlier, that something seems to happen either as we age or with replacement therapy where the titer needs to go a little bit higher. And again, I'll cut to the chase. In my experience, first of all, only as it relates to free testosterone, which we know now since the 1950s, that's where the rubber meets the pavement, and we focus on that more. But because there's a relationship there, I would say, in my experience, 1,500 nanograms per milliliter of total T, which relates roughly to 30 picograms per milliliter of free T, is where I see a complete resolution of symptoms. You're optimizing health. And beyond that, people usually say, well, I don't really notice any difference once we go above that level. Because occasionally you'll run across a patient, obviously, I call them a cheap date, when they don't metabolize it that quickly, and so their levels go even higher. And it's important to note that that's the minimum level, by the way. So what we found is testosterone is very unique in that, unlike, say, thyroid hormone, where you're trying to hit a sweet spot, and too high is too high and too low is too low, with testosterone, really, we only concern ourselves really with too low. You don't want to drop below the therapeutic threshold, because then you won't feel the resolution of symptoms anymore. But my point is that you're going to see a spike in titer in roughly 2.5 days, depending on that mythical average person. And it could be 3,500 nanograms per deciliter. And doctors will freak out and say, oh, he's got you on way too much testosterone. No, it's just the way it works. It's a esterified form, a controlled release form. And just like if you had drank a Coca-Cola, your blood sugar might spike to 180, but it doesn't mean that it's a disaster, it's a problem. Your body adjusts for it, regulates it. And it could be, I mean, I use Coca-Cola just because of the high spike as an example. It could be any meal full of, lots of veggies and lean meats. So that's the concept that should be understandable to any physician, but often gets lost in the mix there. But back to, the levels, uh, Abraham Morgan Taylor, who's associated with Harvard, came up with an international consensus back in, it was 2005, published in 2006 through Mayo Clinic. And it's, I think it's 9 resolutions that go back and actually counter some of what he used to say. Because he used to say, well, there's a cutoff at below 450 total T that, determines whether you have low T. And eventually they came up with, and there's like another 20 experts on this panel. Hey, there is no specific value. Okay, again, this is an international consensus of experts. Duh, you treat the patient, not the numbers, right? Um, and there are a lot more worth looking at. I won't spoil it so that people can go look it up. But dispelling a lot of the myths and rumors about testosterone use, a lot of the propaganda that I would argue surrounded, it's banning in the 1976 Olympics, and of course, then it was a cheating drug and all that stuff. So it led to a lot of, I think it led to a lot of misinformation. But I hope that answers your question.
One of the things I want to touch on when you mention blood testing is the timing of blood tests. So what we do at Balance for Hormones is we test it on the trough. So if they're injecting once a week, then we test right before the next to see what that trough level is, because like you said, it's going to spike and then it's going to drop off again. So you can take 2 patients, let's say the NHS patient that's getting 250 milligrams of testosterone enanthate or even sustanon, and then dosed every 3 weeks. And you can take the same patient and just give them, let's say, 100 milligrams every week. But if you measure the same people at maybe a day or 2 or 3, both of them are going to be probably super physiological, even on the 100 milligram one. The 250 will be much more super physiological, and that's the sanctioned NHS dose. But you're not going to leave them 3 weeks out to being hypogonadal again, and a week later they should come down right, probably about 850, depending on the person. Some people 700 in the US or in the UK. I think somewhere around the mid 20 nanomolars per liter. Or if they're doing like twice a week injections. I've heard you talk about, well, who wants to always bother with so many injections, but for those who can't quite get it right, do twice a week injection or more frequent dosing than that, like what they call microdosing, then you just again test them on the trough, on the right before the next injection is going to happen. Is that how you do it then?
Absolutely. I mean, sometimes just for the convenience of the patient, I've got a lot of, for example, law enforcement guys. They have to go in when they have the day off, so they can't necessarily comply with that. It's great when they can do that for that very reason you're stating, but you can always extrapolate. I mean, you've been doing this long enough. You know the curve and how it works, and you can fit it into their individual genes and how they work. For example, but yeah, I mean that's the key, right? Again, because you're not interested in the peak. I don't know what the LD50 of testosterone is, if there is one. Right? So who cares with the standard TRT dose where it heads at some point, just like that Coca-Cola example. Some people might spike at 160, maybe 180, but who cares? Because we know almost immediately it's going to be brought down to normal or optimum, whatever you want to call it in testosterone terms. We're shooting for optimal, right? So yeah, to your point, absolutely. The best time, if possible, is to check the trough.
Anyway, so I guess we're just following back up. Yeah, we're definitely witnessing a shift in testosterone levels in men today, shifting downwards unless they go on TRT, and it seems like it's worse than anticipated, and that's exactly what we hear. I'm glad we were able to come on the channel and bring some awareness to everyone on the levels of testosterone, what's happening to the levels, and with the levels going up when you're on TRT, it definitely helps kind of preserve your quality of life, make you feel a sense of wellness, and kind of restore kind of a youthful vigor, as well as physical performance.
There are so many misconceptions about this hormone and hormones in general, HRT, which we really didn't broach, but TRT, but all of them, there's, and no one group really, right? Other than urologists in this country have picked up the ball when it comes to men, but I would argue that the OB/GYNs in this country, I'm speaking about the US obviously, haven't seemed to pick up the ball when it comes to women. And it's a shame because, again, when you get through all the baloney, you realize it's not like you're robbing Peter to pay Paul. You're paying a price. I think most of my patients, probably yours, are the same. They say, look, if it came to that, I would certainly take 10 years of top quality life over, a back end 20 where I was miserable or just not as healthy. It's not that way, though, like the propaganda has been. I hate to call it propaganda because I don't think it was purposeful necessarily, but it ends up sounding like that. But that's the beauty of what you're doing here with this sort of thing, is that, we're spreading the word so that people don't have to suffer through a lot. And I can make arguments. I've got a book coming out in January where, I go a little bit into detail about, we didn't broach the topic, but it's related. Anabolic steroids, which are even more powerful in terms of holding muscle on and thereby hopefully promoting more strength. And again, in this country, falls are the number 4 cause of death. And that's a misleading one, because if they don't die directly from the fall, an elderly patient, a lot of them die, a significant number, in the hospital later from pneumonia or something like that. So really the count is even greater. So I don't mean to go off on such a tangent here, but it's just, it's exciting, and it's no longer depressing because of these conversations that we're getting out there. And more importantly, the information that is all supported. I mean, you can go to any of the stuff we've talked about. And if anyone wants help from me or you, I'm sure you're happy to help with the citations where we can reference it from peer-reviewed journals. Okay, not just clinical experience, which shouldn't be ignored either.
So thank you again for coming on the channel. It's been a really, really, real good pleasure. Would you let everyone know where they can contact you? I could put the information within our video in the description, but what's the best way to contact you if someone wants to have an appointment or a consultation?
Oh, thank you. First of all, thank you for having me. I really appreciate both of our efforts herein to get the word out, because it really is kind of a no-brainer if you look at it for what it is. You asked me, our website is www.psr, Papa Sierra Romeo, med.com. And I guess that's the starting point. From there, you can find, whatever information if you want to contact us here. Hopefully there'll be a lot of information on the website that's useful, videos like this that they can start with that might help explain some of the pros and potential side effects, all of which, by the way, we didn't talk about that either. Any side effects, right? Have you ever had one that you couldn't fix?
Have you ever had a side effect of TRT that you can't fix? No, normally there are things you can do to help mitigate the side effects, yes.
Yeah, so, we have a great profession that we practice because, we can sleep at night knowing that, any issue that comes up is fixable. And I can't think of a patient who hasn't been helped by it and is very, very happy. So,
yeah, absolutely. I mean, it's wonderful having you on. So again, thank you.
Thank you.
We want to bring awareness to our audience. We want to educate everyone on testosterone, its effects on health and overall therapies used and tailored specifically to each individual so that you can get back your physical performance, your youthful energy. And this is done through TRT, testosterone replacement therapy. Thanks again, Dr. Rand, and for everyone watching, let us know your biggest takeaway that you've learned from this episode. And if you'd like to have Dr. Rand McClain on again, let us know and we'll make it happen.
Yes, sir.